This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff from Thomas Jefferson University. Today I'm speaking with Brin Freund. Brin is a neurologist at the Mayo Clinic in Jacksonville, Florida, and lead author on a paper published in Neurology in May titled Acute Symptomatic Seizures During CAR T-Cell Therapy for Hematologic Malignancies, Tri-Site Mayo Clinic Experience. In this retrospective cohort study, Brin and his colleagues examined clinical data from patients receiving CAR T-cell therapy across the Mayo Clinic sites in Florida, Minnesota, and Arizona, specifically looking for information about the risk and impact of acute symptomatic seizures in the context of that therapy. Listeners may recall our podcast episode back in January of 2023, in which Derek Stitt spoke with Rachna Malani about immune effector cell-associated neurotoxicity syndrome, or ICANS, also associated with patients receiving CAR T therapy. So while we've talked about neurologic toxicity syndromes associated with this therapy before, we want to bring Brin onto the podcast and speak a little bit more, specifically looking at risks and prevalence of seizures for these patients undergoing this type of therapy. So Brin, welcome to the podcast.
Thanks, Jeff. Happy to be here.
What would you say is the primary lesson you learned from doing this study here?
So I think the most important thing to take from this study is that the incidence of seizures during CAR T-cell therapy is relatively low at less than 5%. Not surprisingly, most of the patients that were at higher risk for having seizures were those that were more critically ill, which was signified by lower minimum immune effector cell encephalopathy score and higher grade ICANS.
Okay, so it sounds like for patients getting this therapy, risk of seizure is low, but if someone's more sick as a toxicity from that therapy, maybe we need to be more vigilant and more concerned that they're at a little bit higher risk of seizures. And so given that, let's refresh a little bit about CAR T and the different neurologic syndromes we need to watch out for in patients receiving this therapy. And you mentioned some severity scores of neurotoxicity from this therapy. So if you can remind us, what is CAR T therapy for patients with cancer, and what do we already know about the potential neurologic manifestations that could pop up for patients undergoing this therapy?
CAR T-cell therapy is an immunotherapy that is given by using a patient's own T-cells, and the T-cells are modified to allow them to target certain pathological cells in the body that are used to treat diseases. It is currently used in treating cancer, specifically those of the blood, but also being studied in other cancers and potentially in treating autoimmune diseases. When we look at prior studies and talking about neurotoxicity, the condition is called immune effector cell associated neurotoxicity syndrome, or ICANS. And ICANS is not uncommon, and it can occur in up to 3/4 of patients undergoing CAR T-cell therapy. The symptoms are variable, but they can include altered mentation, confusion, and even severe enough to cause coma. This can be related to brain edema, as well as seizures. And there are other neurological manifestations such as focal neurological deficits and tremor. The pathophysiology is not really well established, though it's likely related to a systemic inflammatory response and then subsequent breakdown of the blood-brain barrier that leads to direct effects on the central nervous system.
So in patients undergoing this therapy, as we've talked about on the podcast before, and as you summarized, be on the lookout for changes in mental status, anywhere from confusion to coma. There may be some edema changes that are seen on imaging. And then, as you said, there might be movement disorders like a tremor. And then, as we're going to talk a little bit more about, seizures can be part of that syndrome too. This was a retrospective cohort study across the Mayo Clinic sites, patients who are receiving CAR T therapy. Can you tell us a little bit more about these patients? Are they typical of patients getting CAR T? What would be good for us to know about the patients you studied here so that we can calibrate our assessment of patients we then go forward and encounter in clinical practice?
So the study included 180 patients, primarily undergoing CAR T-cell therapy to treat leukemias and lymphomatous cancers, which is a typical indication for treatment. The average age was around 62 years, and there were slightly more women than men in the study. Only a few patients had pre-existing neurological disorders that would make them prone to seizures, and it was a decent representation of the general population.
Okay, so it sounds like a pretty typical cohort. You mentioned CAR T is being studied in some other malignancies, but this was a hematologic malignancy treatment context for these patients. And as you said in your previous answer, we know that ICANS is not uncommon and maybe even occurring in up to 3/4 of patients undergoing this therapy. And seizures can be part of that syndrome. So let's dig into that a little bit more. What did we know about risk of seizures coming into this study? Did we have any earlier clinical data about how often seizures are manifesting in patients getting CAR T? Or what did we know that this study is building upon?
So it's interesting because you're right. There have been previous studies looking at seizures in these patients, and they typically would lump them together with other neurological toxicities. There are also studies looking specifically at EEG findings in these patients as well, but not really combining the whole story in terms of the clinical and EEG aspect. And our study included 180 patients, so it was one of the larger studies on this topic. Now, there have been studies looking at seizure incidence, and for example, there was a study looking at treating glioblastoma, and 30% of patients had seizures and focal neurological deficits, but obviously these are brain tumor patients, so a little different than patients with hematologic malignancies. Other studies are looking specifically at patients undergoing treatment for hematologic malignancies have relatively low rates. So there was an example of a study in 2019 from Rubin et al. Where they looked at 100 patients and only one had clinical manifestation of tonic-clonic seizures. And then another patient actually had non-convulsive status on EEG monitoring. Another study from France, which included 4 sites, actually demonstrated 3 patients out of 84 having tonic-clonic seizures. So again, relatively low rates of seizures. Of course, as I just alluded to, a lot of the studies didn't have a thorough evaluation of EEG and clinical correlation, and we know these patients are at high risk for non-convulsive seizures and non-convulsive status. So our study put the whole story together to really see if these patients not only are having clinical seizures, but also subclinical seizures, which is an important thing to consider.
So let's dig in a little bit to that 5%. And so in going into some more detail, what did you all find with regards to potential risks or maybe differences in outcomes in patients who had seizures versus those who did not? And you mentioned a little bit about if their ICANS syndrome is more severe, that might modify our risk. But how do we see these patients undergoing therapy and try to get a sense of their risk of seizure? Or if they do have a seizure, how do we potentially consider their future and their risk on the other side of that?
So yeah, Jeff, as you note, the rates of seizures are relatively low in these cohorts. So a few more bits of information from our study. So the average time to onset of seizure after the infusion was 8 days, plus or minus 5.3. And 3 out of the 8 patients actually had seizures that began greater than 7 days after their infusion. Now, all these patients had cytotoxic release syndrome at the time of the seizure onset, but none of these patients had recurrent seizures outside of the acute phase of their illness. So none of them actually ended up being diagnosed with epilepsy or needing long-term anti-seizure medication treatment. And when we did our univariable analysis, we found that exposure to cefepime, earlier onset of cytotoxic release syndrome after the infusion of CAR T cells, worst grade of ICANS, and focal neurological deficits were all associated with a high risk of seizures. And then the multivariable analysis we did, we accounted for age and sex and found that lowest minimum ICE score and worst grade of ICANS was associated with seizures. So as we already alluded to, basically more critically ill patients were more likely to have seizures. And in terms of the outcome that you mentioned, I think the one thing to keep in mind is that all the patients that had acute symptomatic seizures did die as of their last follow-up. And this was significant when compared to those who did not have seizures. Now, the question would be, is there a confound that would make them more prone to having seizures and subsequently determine their long-term outcome? We didn't really dig into that, but that's certainly something to consider.
It sounds like if that ICANS syndrome comes on quickly and with severity, that perhaps makes sense that they're going to be at higher risk of seizure. And as you said, looking at the outcomes, the patients in this cohort who did have seizures have all died at their last follow-up. But again, is that a function of the severity of their syndrome? Does it have something to do with the seizures that itself? Not quite sure. Is that, I'm hearing you properly?
It's hard because there were no differences in short-term outcomes with seizure versus not having seizure. So it's hard to say, is it really directly related to the seizures themselves? Or is it something that's just these patients are more prone to having seizures and therefore they're more prone to having a worse outcome from CAR T cell therapy?
I want to get into a little bit of some of the trickier questions that maybe this study is maybe not fully able to answer. And that's really talking about seizure prophylaxis with anti-seizure medications. And we know that seizures have in and of themselves a risk of morbidity and mortality. You mentioned that patients who had seizures in this study have died at a significantly different rate than those who did not. But again, that could be confounded by their ICANS severity. We know in other contexts, such as intracranial lesions or hemorrhages, that there are instances where we would prescribe someone an anti-seizure medication to prevent seizures in a high-risk setting. So what about in this context? Did this study give us any clues as to whether patients undergoing CAR T therapy, or perhaps they have other clinical features of an ICANS syndrome in which we would say this person should be treated with anti-seizure medication, or are we not there yet?
So I think it's a really tricky question, as you point out. And we all know, and as you also alluded to, that anti-seizure medications are not benign, and we always recommend cautious use. And this is especially true when we think of critically ill patients where we could potentially worsen their encephalopathy and their outcome if we're over-aggressive with medication. Our studies suggest that sicker patients are more at risk for having seizures, which makes sense. So this could potentially be used as a guide to consider using anti-seizure medication. But frankly, we just don't typically recommend prophylaxis in critically ill patients as a general rule. So it's really hard to give a specific indication to use it prior to the onset of seizures. Unfortunately, anti-seizure medication prophylaxis has not been prospectively studied, so it's hard to give definitive recommendations. Now, there are a few studies that have looked at prophylaxis in these patients, and there was one particular study from Italy where they looked at 156 patients in whom they gave two different forms of prophylaxis. One was used primarily prior to treatment with CAR T-cell infusions, and then the second was a preemptive approach where at the onset of neurotoxicity, they would start anti-seizure medication. They found no difference in terms of the incidence of seizures or outcomes when comparing the two groups. But again, they didn't have a control group without prophylaxis to compare to. Now, our cohort had a significant number of patients that were not treated with prophylaxis, but all the patients that had ICANS did end up getting prophylaxis. So it's very hard to say, did the prophylaxis itself really reduce the incidence of seizures because it was used in sicker patients, or are we just too aggressive with these medications given the low incidence of seizures? And that's not really clear as of this time.
As you said, one of the issues with a retrospective cohort is you can't control or adjust for patients who did or did not get prophylactic anti-seizure medication dosing. And I want to ask another follow-up that maybe not anti-seizure medication, but what about EEG electrophysiologic monitoring, right? If someone's developing an ICANS syndrome, maybe we don't prophylactically prescribe anti-seizure medication, but what are your thoughts on hooking them up to a continuous EEG? And that way, if they do develop seizures, convulsive or non-convulsive, that hopefully the team knows quickly and then can intervene. Is there evidence on that? Is there expert opinion in that realm that you can speak to?
So I think EEG is an extremely useful tool. In general, we all know that using EEG in critically ill patients can help triage the use of anti-seizure medication and potentially the need for continuous EEG monitoring. So I 100% agree with you. If someone develops ICANS and there's a concern for potential for seizure, an EEG is totally appropriate to try to discern, number one, is anti-seizure medication necessary? And number two, is a continuous EEG going to be warranted to help monitor for subclinical or non-convulsive seizures?
Based on this data set, based on what you learned, how do you plan, or how have you found yourself counseling oncology colleagues differently, or are you changing the conversation you have when you encounter patients who are undergoing CAR T therapy? How does this affect just day-to-day practice, at least in your world?
So I think there's good evidence at this point to suggest that the incidence of seizure in these patients is generally similar to a critically ill patient that we encounter in the hospital. And so I think we should probably approach it similarly in that we don't regularly use anti-seizure medication for prophylaxis for seizures. So I would really recommend a conservative approach when considering initiating anti-seizure medication for prophylaxis in these patients. Specific recommendations are hard to make because we don't have that prospective randomized data to guide us. But I would strongly urge discontinuation if anti-seizure medication is going to be used. I really see no reason to maintain it after the acute phase of their illness. So once cytotoxic release syndrome or ICANS is resolved and there have been no seizures, that's the time to stop the medication. In terms of using prophylaxis, though, I think the jury's still out and we need more data to guide us.
So to try to summarize some bullet points from that, think of these patients as we do other critically ill patients when we're figuring out what is the risk that this patient is going to have a seizure. We're not at a point where there's enough evidence to prophylactically prescribe them anti-seizure medication. If they do have a seizure, it's likely a symptomatic consequence of the edema and the CNS changes from the neurotoxicity syndrome itself. And there's not much data, or there's not any data to say we should keep these patients on long-standing anti-seizure medications. And don't be afraid to monitor them with EEG so that if there is a seizure that occurs, you can triage and treat appropriately. Is that where we're at?
Yes, I would approach them similarly to any critically ill patient. That's right.
Awesome, Brin. I've been speaking with Brin Freund from the Mayo Clinic in Jacksonville, Florida, about his study published in Neurology titled Acute Symptomatic Seizures During CAR T-Cell Therapy for Hematologic Malignancies, Tri-Site Mayo Clinic Experience.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.